and welcome to this meeting of the Health Scrutiny Committee, which is now being broadcast live. Can I accept the minutes as a true and correct record of the last meeting, please? Thank you. James, do we have any apologies for today's meeting?
Okay, so we have received apologies from Councillor Michelle Welsh for other reasons and Councillor Steve Carr for other reasons. We also have apologies from Sarah Cardis as Chair of Health Watch, but in her place as a substitute we have Sabrina Taylor, who is the CEO of Health Watch. And just to have an update on the membership, that Councillor Paul Henshaw is now a full member of the committee in place of Councillor Maggie McGrath. Thank you, Chair.
Thank you, James, and welcome Sabrina to this meeting. Do any members present have a disclosable or pecuniary interest to declare? Councillor Eddy.
Just say that I'm Chair of the Health and Wellbeing Board, which means I'm also the Vice Chair of the ICP and appointed Governor at Sherwood Forest Hospital Trust and Nottinghamshire Healthcare Trust.
Thank you for that. Mrs. Haley. Do any members present have a private interest pecuniary? Oh, sorry. Councillor Wilmot.
Yeah, I'd just like to declare an interest that my daughter works for the NHS. Okay.
Thank you. And do any members present have any private interest, pecuniary or non-pecuniary, to declare? No. Right. The next item for consideration is a report from the ICB, which was requested as part of last year's work programme and has been prioritised because of intersections with the ICB proposed financial sustainability measures which affect community pharmacies and GPs. I would like to welcome the representatives of the ICB, Caroline Golding, good morning, Primary Care Director, Rebecca Dickinson, is Rebecca not? Yeah, yes, good morning, Community Pharmacy Clinical Lead, and Alex Bohr, Director of Communications and Engagement. I think, David, you're here for the next item, I believe. Yeah. Or you can take part in this one if you wish, yeah. And David Briggs, okay. So thank you, Caroline, Rebecca and Alex. Can you sort of do your presentation, please?
Yeah, thank you, Chair. Dr. Briggs is going to kick us off actually for this one. Thank you.
Got to turn my mic on. Rookie error. So, really important topic about the relationship between general practice and community pharmacy. There are a wide group of services that are provided in primary care. And primary care we describe as community pharmacy, general practice, optometry and dentistry, all of which are really important services, the access to which can significantly affect your life, quality of your life, and how you experience your health care. The majority of all interactions, including if you include dentistry and pharmacy, occur in the primary care sector, and most experience that people have on a day-to-day running or day-to-day is in the primary care sector, and community pharmacy be one of the really common areas that people interact. So we have got quite a wide variety of community pharmacies in terms of the size, scale. Some are large groups and some are smaller, independently run organisation, and there's some in between. So the operating model differs greatly. There are quite a large number of them. There's 216 in the county and 58 in the city, and they offer two groups of services. One is essential services, which every single pharmacy has to offer to have an NHS contract, and that is dispensing medications and all of the work that goes alongside that, ensuring the right medications, the right information is passed to the individual or carer taking those, and sometimes arranging for those medications to be delivered or put in dossier boxes. The second is to give minor ailment advice for those people who have got a condition which is less serious and are at the pharmacy. They can ask them about that, and that's part of the essential services. And the last is to advise on over-the-counter medications. The vast majority of pharmacy income currently sits in that area of funding. There's a second area of funding, a second area of services that we've been working locally and nationally on with community pharmacy, recognising they're often in the heart of the community, are often more easily accessible than other healthcare sectors, and there's an existing relationship which is very important to our citizens with those professional colleagues. Most important of which I think that's really come out recently is Pharmacy First, and many of you will have either seen on a very effective comms campaign or actually experienced in terms of experiencing it, being able to go to your community pharmacy for a number of common conditions and receive a prescription if appropriate for those. And that is really important in terms of that less serious conditions, but really need to be able to access it really quickly to get on top of that. And for me, it's an area that is going really well received by community pharmacy. And it's an area that we've worked on with local GPs and local community pharmacists about how we can make that even better for our patients. And I'll come into that work later. The second area is the second group is those less complicated pathways around almost health improvements or hypertension diagnosis, the oral contraceptive and vaccinations, which you can access your community pharmacy of. And in some areas they provide smoking cessation, although that isn't something that our local pharmacists do. So we have developed, go next slide please, we have developed a very effective and well thought of relationship with our community pharmacists, actually. Something I've personally spent a lot of time in the last 2 years doing. I've been to visit a whole series of community pharmacists trying to understand what problems they have, worked at place level with community pharmacists and GPs trying to understand how those interfaces work. And we've developed a monthly task and finish group to try and resolve some of the ongoing issues that are between those two sectors. And to give a flavour of that, one of the biggest concerns that general practice and pharmacy have is around the availability of medications. Many of you in this room will have had their runaround trying to find available medications. We've really worked to reduce that locally. It's not where we want it to be, but we've got those relationships and those things, trying to work through the issues with really good engagement with our community pharmacists. And a number of us have been and work regularly with the local pharmacy committee in other areas. And we have a local place-based meeting with community pharmacy to start integrating them into the neighbourhood teams as they develop and progress. So compared to other ICBs, I think we're in a good place, but work to do. The one on there that I've not talked about, which I want to talk about next, is independent prescribing pathfinder. I think everyone would recognise that we don't fully utilise the full skills of our pharmacy colleagues. You know, it's a long training programme. They've got a whole heap of skills and expertise that we don't always fully utilise. The independent prescribing pathfinder, which is in Eastleigh, for those who know, obviously just across the river, and it's a way of learning how we can best utilise those skills more widely. There's a number of those pathfinder trials happening across the country, and the plan is we'll use those to think through what the potential futures of community pharmacy could be, and how we can expand those services with a view to increasing the stability of community pharmacy, making it a more attractive place for pharmacy graduates and current pharmacists to work, looking at how they integrate to become a wider part of the MDT team in primary care, and also those professional relationships developing. So it's how do we move from the ongoing predominance model of care about dispensing and around drugs to around how they can be more integrated into offering more healthcare advice. So that is an interesting piece of work we're currently going through. Have the next slide, please. So, is this you? Is this you? Is it me, sir?
It's me, I think.
Okay. Otherwise, I'll talk and I'll get told off.
No. Okay, so I think what I would say is community pharmacy is changing. Traditionally, it's been a supply and dispense model where you went to got your medicine from the GP, you went to the pharmacy, and that still forms part of a large part of their contract. I would still say around 80-85% of their contract comes from the dispensing of medicines. However, that is changing. Dave's talked about the clinical services, and actually we're in a process nationally of transforming the services. So actually the future will be that actually community pharmacy will be the first port of call if you are poorly, to go in and see whether it's pharmacy first. We are very advantageous because the previous work before Pharmacy First came out came from the East Midlands, and Nottingham was a forerunner on it. So a number of the services that were included in Pharmacy First actually came from the learnings of the pilots we did in this system. Obviously, the independent prescribers are going to change the face of it as well, and this is on the back of the fact that in 2026, pharmacy graduates are going to come out with an independent prescribing qualification, which will fundamentally change their offer to patients. So the independent prescribing pilots are really, really important, because then that makes us understand about, well, how can we pivot that resource and that workforce into our communities. I think the other area to touch on is COVID did change community pharmacies. I will say that at the first wave of COVID, our community pharmacies were the only first line of call that were fully open. They had to stay open even behind closed doors. And obviously the model that we developed through COVID vaccine has actually been a forerunner. So even though we're only doing around 25% of our vaccinations through community pharmacy in Nottingham, we're predicting that over the next coming years, more of our patients will go to community pharmacy because it is more accessible, it is on the high street, it is in locations people shop instead of having to go and buy and get an appointment. One of the asks of this paper was to actually talk about the complexities and the financial challenges community pharmacies are seeing. And obviously we had the piece in the local media where a local pharmacist said, I am under significant strain and struggle, and I don't know how I'm going to manage in the future. I think just to bring some context, the commissioning of community pharmacy is complex because it's nationally agreed and negotiated. Then there's some elements that are commissioned by us as the ICB. Then there are elements commissioned by the local authority as well. So it's not just one pot, one contract. I will say at the moment they are having some struggles nationally with negotiating this national contract. It is a priority for the national team, and we are feeding in as an ICB our views and thoughts. I would say that's something as nationally NHS England are trying to land very quickly because of the work they want to reform in Pharmacy First. But one of the other areas we are working on is we are trying to assess what the new pharmacy contract model will mean. There have been some concerns that we are having pharmacy closures. We're not seeing that at the minute. We've had one this year, and in comparison to the previous years, we have seen a decrease. What pharmacies may start considering is reducing their opening hours and their operating hours, and they would have to apply for that, but we're not seeing a huge amount of that. That's half and half. Some are coming to us to saying they want to reduce their hours, but then we have other pharmacies saying we want to increase our hours, and obviously we're supporting that. We work very closely with the local authority because through that work we do a pharmaceutical needs assessment, and that document articulates to us as commissioners and the local authority, have we got any gaps in service? At the moment it's not showing that we have any gaps. However, we have relaunched that P&A again, so we are going to be doing another look at that to see the outcome of the change in society, changing our demographics, changing policy. Have we got any gaps? Obviously if we do have gaps, it's not similar to GPs where we would go and procure a service. Pharmacy contractors and individuals can apply to the commissioning board to open pharmacies, and we would then consider that against the pharmaceutical needs assessment. So just to summarise this last part, I would say that community pharmacy is under a bit of strain at the minute. We are seeing some concerns in how they pivot to the new future. As an ICB, obviously, we are in a financially challenged position, and we are looking at ways in how we can support community pharmacies in the future. But some of the really key pieces of work we are doing is we are trying to bridge the gap and build relationships between general practice and community pharmacy. And actually that's where we are seeing the biggest transformation and sustainability of service, when we get people talking to each other and just coming together to provide the service in their local areas for the population. So thank you.
Is that end of presentation? Thank you very much for that. That was very interesting, and a good update. I think it's very important, that this partnership working between GPs, pharmacists, and the ICB going forward can relieve a lot of pressure on GPs and help with the dispensary of drugs and this, that, and the other going forward. I think there's a lot of work to be done. I think there's a lot of good can come out of this. So I'll open this up now to members who want to make any comments. Councillor Henshaw.
Thanks, it's very interesting. Thanks for your contribution. Looking at the report, and you mentioned it about the wide range of operating groups within pharmacy. How easy was it to include everybody in the discussions around the proposed changes? Because it might be difficult to draw people to the middle to get views. And one of the recommendations in our minutes is regarding the quality impact assessment. It seems how's that going? Because it says it's going to be brought to the next meeting. So I just wondered how that was, the quality impact assessment was being worked on. Thanks, Chair.
That was my question, but we'll pick that up in the work programme going forward. But yeah, Councillor Martin.
Yeah, thank you, Chair. As Mr. Briggs alluded to, they cover a wide range of services, and we're not here to talk about dentists and their wholesale abandonment of NHS patients under the contract. We're focusing on pharmacies. Now, last year I had an issue with a pharmacy in Selston, which is part of a chain, and I do worry about adverse impacts on pharmacies, especially when it's part of a chain and it's in a rural location like Selston is, as opposed to Eastwood, where they're in the urban conurbation. They've got 9 pharmacies on the high street and around, and there's plenty of choice for them to go at. In Selston, where we've only got one, when the wheels come off the bus, they do come off the bus. And I in the past, the only accountable body for pharmacies was the Pharmacy Council. So when something goes wrong with a pharmacy, we are referred back to the Pharmacy Council, which of course is run by pharmacists. And my question to you about that is, what accountability would there be? Because when there was a problem with that, the ICB put us straight back in touch with the pharmacy itself. So we're in a round robin, and there's no resilience plan. So when something goes wrong, I'll give you 2 examples. We've got one in Brinsley as well, where I know it's only a small scale thing, but it's really important. When the person who used to deliver the pharmacy out didn't turn in. There was no resilience plan by the pharmacy to support that, and so obviously people weren't getting their prescriptions delivered. And I know we've got more broader, internet stuff, but people tend to be creatures of habit and go back, and they're referred by their a lot earlier. The doctors used to prescribe and actually, dispense medicine, and that actually helped to support their financial costs. So I lost my doctors in Underwood itself because they took that right of the doctor away and gave it to a chemist in the next village. So not only did I lose the doctor, I lost the pharmacy dispensing in the village as well. You know what I mean? Because we had a change in the system. So the other adverse impact that I would worry about for pharmacies themselves is the increase in the national insurance and the effect that's going to have on employing staff that deliver these services. And I think it's great that they are going to broaden the scope of the service next year, but it has to be sustainable, it has to be reliable, and they are 2 things that currently I'm not seeing 100%. It is a lot better idea, and of course it came about because of COVID, like you say, quite rightly point that out. But we need to make sure it's definitely sustainable. Thank you, Chair.
Do you want to take Alex? Yeah. Or...
So there's quite a bit in there, and we shouldn't lose Councillor Henshaw's point as well around sort of how we brought people to the table and kind of engaged. But Caroline, do you want to pick up some of those?
Bringing people to the table is quite challenging. I think we started seeing that in COVID when we came out nationally and said community pharmacies have a part to play in the COVID vaccine response. I think as an ICB, one of our biggest roles is to bring people together and to build the networks locally, because actually that's where they make the difference for patients, and that's where they solve operational issues really, really quickly than if me or Dave have to get involved actually. So it has been challenging. I think it has given people the time and the space, and we're very lucky with in Rebecca's role, that's her role, to bring people together and get people talking. And we have allocated capacity within our primary care teams to actually be that network, to be the conveners of bringing people together. It just takes time. It's not something that happens overnight. And obviously we're all very aware of the pressures within general practice, and that brings a different level of complexity into it. The more technical questions on Councillor Martin. So deliveries is a challenge for pharmacies because it's not under the contract, and it is a goodwill. It is a goodwill service. Obviously, with all the regulation change they're bringing into the community pharmacy, the dispensing of medicine is changing. So they are looking at, if you look at the model going forward, that you will have community pharmacies providing far more bigger ranges of clinical services, then the dispensing of medicine has to be done somewhere else or in a different way. So there's a lot more provision now, nationally and locally, for online prescriptions. Now that won't work for every patient. Completely understand that. So it has always a problem. The other bit you mentioned about dispensing in rural areas, that is problematic. It is problematic. Dispensing rights was brought back in many, many years ago, and it was there to support general practice in rural areas where they didn't have the patient numbers. We still do have a number of dispensing doctors in our county that are providing fantastic services. What I would counter is that a dispensing doctors does provide a different level of service than community pharmacy. They can't provide pharmacy first. They are unable to provide a number of services. So for us as an ICB, it's about making sure that we have that right mix of services, because community pharmacies in rural areas do work because they do provide a different level of care and service for that rural population. National insurance is a challenge for every primary care provider. It is, because they're all independent. They're all independent contractors, so they're not covered under contracts such as our trusts in our county. Because they are nationally agreed, that is something we are raising with national colleagues, because the national contracts agreed, the financial envelopes are agreed nationally. So we are working really closely and lobbying as an ICB, our national colleagues, to make sure that that factor is really included in their thinking. And we are, when we go out to providers, we are asking, tell me what your direct impact of NI is, so we can feed that in. But yeah, that is a challenge that we haven't got a mitigation for at the moment.
And Caroline, I think it was a really good question from Councillor Martin around that Selston kind of sort of potentially isolated pharmacy, and that interrelation between the local pharmaceutical committee and the ICB and the chain that might run that's quite a crowded space, isn't it?
It is, thank you. I had forgotten that, so apologies. The ICB was delegated pharmacy services last year from NHS England, so we did have a relationship with community pharmacies, but it was a bit more distant and remote, and it was through another organisation. Going forward, if we were to hear that we had that problem, if Selston came to us, we would then be wrapping a level of support and a conversation around to see what they can do. It is probably more robust. When I look at the community pharmacy sector, they are slightly more robust when they have chains, because they have different levels of workforces and can move staff in. That doesn't happen because we do have independent pharmacies in rural areas as well. But we are getting, part of Rebecca's role and my role is to make sure we have that operational awareness. And if we do get concerns raised, because we get concerns from a number of areas, Health Watch, patients, our patient experience team, GPs, all sorts of providers, we will go out and meet with pharmacies to understand what their issues are and see what we can put in, even as a temporary measure to keep the pharmacy going, because it isn't in anyone's benefit. We would struggle to replace a pharmacy in that area because of the rural location.
Okay, yes, thank you for that. Yes, I'll bring him in a minute. But I was just thinking, you mentioned the finances there. I'm just going to say, how are the contracts and the finances? Is it a national contract, or does it come out of our local ICB budgets, or is it independence different from community pharmacies? You know, because I get the impression that some pharmacies are struggling financially wise to with the service they provide, but they aren't financially represented for it.
The way community pharmacy income is generated, there's a national contract that's negotiated by NHS England, and that deals with the just the supply and dispense of medicines. So depending on the amount of items they dispense per month, that then gets sent off, and that's calculated in a monthly payment. I would say that probably takes around 85% of their income. Then the other 15% is made up of, like, our local enhanced services probably constitute around 2 or 3 up to 5% of their income, depending on how well they provide and what comes through the door. They don't have a guaranteed level of income because often with their services it is a walk-in or it's an appointment, so they can't guarantee that they're going to see 50 patients a month for the COVID vaccine. It depends on bookings. And then obviously community pharmacies do sell medicines, and that is part of their business. They can sell obviously PMEDs, and they can sell and supply far more medicines over the counter than dispensing doctors can. So you talked about the differences between dispensing doctors. Dispensing doctors aren't able to supply what we call pharmacy only meds, whereas when you go to a community pharmacy you can see an array of medication. And I would say that medication is getting larger every year, actually. Government and the department are looking at different ways. So instead of having to go to a pharmacist for a consultation or a GP, actually you can go to the pharmacy and potentially purchase, obviously if you can afford it, that medicine without having to go somewhere. So it is nationally around, and obviously some of our community pharmacies will have contracts with the local authorities because there will be some public health services that they provide, smoking cessation and various other bits.
Thank you for that, Sabrina. So,
Hi, thanks. So we have just literally finished our pharmacy report where we did a little bit of research and spoke to people about their experiences. And I guess the question I have is, in terms of these changes that are being proposed, where does the patient voice fit into all of that, and how are you ensuring that patient voice is going to be reflected in terms of understanding the impact? So the main thing that came out of the report that we've just published, hopefully in the next few hours, was around accessibility, medicine supply shortages, which you've already talked about. Reasonable adjustments came up as a concern. People talked about the fact that their needs were not really being fully met, or they couldn't understand why reasonable adjustments couldn't be made. Payments for prescriptions came up as a concern, and Pharmacy First was a bit of a mixed response. So lots of people said it was great, other people said, well, we're not sure about it, we don't understand it. So I think one of the things that we also would like to understand is communication to patients, and how is that being looked at, and how are you ensuring that people can really understand and be clear about why there might be shortages of medication, or how to access Pharmacy First, and things like that.
I'll take that one if that's all right. I've been very excited about this report, and I got a preview about it the other day, and I think communication in there is really key. And because Healthwatch were able to share some of these things in advance with us, we have started to have conversations about how we do this, because Pharmacy First was very new. It was very new for the healthcare professionals involved, but it was very new for patients as well, for people. So for everybody to understand, it's all been very new. And we tend to use words like prescribing in a kind of generic term, but actually these are patient group directives, which are very strict protocols. So there was a lot of understanding of things that are quite complicated to understand. So as an ICB now, we have a community pharmacy page, and we have summarised all the community pharmacy services. we hope in patient-friendly language, but obviously if Health Watch, have any comments, that'd be great to hear. To try and explain these things, to try and show patients where they can get services. It has been mentioned earlier that we've been doing some work around Pharmacy First and partnerships, and as part of that task force work, we've been doing quite a lot of social media work, and we've been replying to patients about some of the questions. The most common one being, why is it only women for UTI, urinary tract infection? And it is simply due to anatomy. These are about simple infections being managed, so that the more complex infections can be seen in the GP's surgery. So we're starting to respond to some of those things. I think communication is a journey, and it's something that we are working hard on, and look forward to be able to do some more work with Health Watch to increase that communication.
Councillor Wilmot.
Thank you, Chairman, and thank you all of you for the informative presentation you've given for us today. I've got a couple of questions that I need to be informed about. What are the specific impacts of the current fragmented commissioning structure on service continuity and patient care in both Nottingham City and Nottinghamshire? The report mentions that the complexity of commissioning being split between the NHS, local authorities and integrated care boards. How does this division affect the ability to deliver consistent and coordinated services, and what steps are being taken to mitigate any possible potential gaps in service provision? And finally, my second question is, how are the evolving roles of community pharmacy, particularly in prescribing and clinical services, being integrated into the broader primary care system? And are there adequate mechanisms for collaboration with GP practices? With the introduction of initiatives like the Community Pharmacy Independent Prescribing Pathfinder and Pharmacy First services, how are the community pharmacies and GP practices collaborating to avoid duplication of effort and improve patients' outcomes? Are there sufficient communication channels and referral systems in place to ensure a seamless integration of services? One of the issues that comes up on a regular basis that people are asking me about, and I'm got the same problem, is the repeat prescriptions. When I actually go to the pharmacy ready to pick up my repeat prescription, it's never ready. It's down in the surgery to be done, but I have to go back to the surgery and inform them what's happened. We'll put it through now, and it'll be 24 hours before you can get it anyway. So that for me is a real problem. The pharmacists, can we possibly get them to work more closely on that issue? It's a serious issue because I'm getting it regularly, because I'm part of the one of the Wyburn group representatives, and also people are telling me what the problems are, and also vaccinations. What is the situation when somebody actually goes for a vaccination at a pharmacy and has got an allergy for that vaccination, and actually the surgery knows about it, but of course the pharmacy wouldn't know about it? How do you integrate that service to make sure that it's safe? Thank you very much.
Yes, thank you, Councillor Wilmot. I will say about the repeat prescriptions, the NHS app is very good to get your repeat prescriptions forward, yes, which I use all the time. Thank you.
Thank you. So there's a few issues there, aren't there? So I don't think, well, I know that fragmentation of commissioning isn't the primary problem that community pharmacists are facing. What they're facing is a difficult operating environment within the resources they've been allocated as part of the national process, that we are supporting them by feeding that back to national teams. They're also going through I think a pivot point in terms of what we as a country, as a community, want them to do, and move from a dispensing service to a healthcare service. Those two things and those changes aren't easy for any group of providers to manage, and so the split of commissioning, given the relatively small quantum of services that are commissioned by local authority colleagues, by ourselves, given the small number of those and the small percentage of their overall contract, their issues are around the vast majority and how we sort that. That's why we've had quite a lot of work with our local pharmacists to try and resolve some of the local operational issues that we can help and support with. So a number of things pharmacists have told us that they would like us to resolve and work on. One is the no available meds issue. So this is where you go to a doctor, they prescribe something that should be readily available, and due to a national or local availability issue, it's not, and you have a bit of a ping pong trying to work out what happens as an individual you go around. We've done quite a lot of work to try and reduce that from happening. It wouldn't be uncommon for a community pharmacist to spend 6 hours trying to find that medication for you, which is clearly a lot of their time. And if we can reduce that happening, they've got more time to continue their work and be available for you. So that's been a key area. And there's been lots of work introducing general practice to community pharmacy to think about how they can make their repeat processes more seamless so people don't get caught up into it. And I think there is a role here for the NHS app for those who can use it, because that does make it a little bit more effective in terms of not having too many points of contact. So we are working with community pharmacy and primary care to look about how we can resolve some of those operational issues. Unsurprisingly, general practice don't want this state of affairs, and neither do community pharmacy, so they are trying to work it. It's in no one's best interest for people not to have their meds when they're available. It's in no one's best interest for people not to have available meds. However, some of those problems are quite difficult to resolve, one of them being information technology and how the systems work together, and that's a task that our Director of Digital is looking at to see if there's anything we can do more in that domain to reduce some of these handoffs that you described. And the last thing for me is around the allergies and you mentioned around how do community pharmacists know the allergies. So the vast majority of allergies are allergies to a very specific way in which vaccines are produced, egg allergies, and that information is on the summary care record that the pharmacists have got access to as part of their services, and also people are well aware on the whole that they're available to it. So the risk of people being vaccinated with something they've got optic allergy is very low, and if it did, it's something that did happen. We had an anaphylactic response on a known person with an allergy. It's something we would investigate thoroughly to understand why that happened, how we could prevent it from happening, and how we could maintain a safe vaccination process in community pharmacy. I've not seen one of those since my time in Nottingham in the last 3 years. I'm not saying they haven't happened, but I've not been involved in any yet. I would expect to be.
Councillor Duddy.
Thanks very much. Yes, I mean, they've touched on the holy grail of the ubiquitousness of pharmacies throughout the country, and our failure to date to be able to capitalise on the dovetailing of that with primary care. But that's the vision as we go down the line, and we've all been used to going abroad and getting enormous services from pharmacies that we wouldn't have dreamt of getting back here. But the platform of care as we move forward has diversified to such a degree that people are now trusting the idea that they can go to a pharmacy and get care, because in general practice less than 50% of appointments are by GPs, they're by pharmacists, they're by advanced care practitioners. So the idea that service has to be uniquely provided by a GP is being slowly diluted in a very positive way. So I suspect that down the line this is something we've been trying for years with Pharmacy First, but I think necessity is the mother of invention, and we're being driven to create a success out of this. So I think it's quite good in that respect. We've got a couple of areas. One, when we touched on the joint strategic need, the pharmaceutical needs assessment, is that we haven't really touched on the effect of the internet and the provision of the internet versus the provision of the normal corner shop pharmacist. And we've seen it particularly with Wegovy and weight loss drugs, where huge amounts of drugs are available to people with the minimalist amount of pre-assessment with regards to that. And I think it's one of those, from a safety point of view, that would be quite interesting to look at later on. It's great that the education of pharmacists is changing to be prescribers before they leave, so that the model of the new pharmacist will actually encompass the idea that they are more than just a dispenser, that they are actually a provider of commissioning as well as everything else. If we could teach them how to pull teeth, Chair, at the same time, we would resolve many of the country's great challenges. For me, it's a practical problem. We look at things and we see, yes, this would be great. But when I go into the pharmacy and watch them doing what they do, number one, the premises are not of a standard that we would expect in general practice. The consulting rooms are not of a standard, and the ability to deal with allergies and unexpected consequences in the absence of even tables, etc., and vaccinations are not. Confidentiality is often an issue when you're standing at a counter. Timing. So when I was in the pharmacy last, there was a big queue. So I said to the dispenser, "What's that big queue all about?" I said, "The pharmacist is in the room taking somebody's blood pressure or dealing with an ear infection, and while they're away doing all the commissioning work, there's nobody doing the dispensing work." So we've got the challenge of the fact that on paper it looks really good, but with the same person doing two different jobs, it translates into a very practical challenge within the practices with regards to the fact that the estates and the provision of confidentiality and safety simply doesn't exist. It's challenged in general practice, but nothing like it's challenged there. One of the things you were talking about, Dave, was pharmacies and a lack of medication. And I'll send a prescription to one pharmacy and say, "Have you got Betnovate?" And they'll send the patient back. The pharmacist says there's no Betnovate. I'll send them to another pharmacy and the patient will come back and say, "They have no Betnovate, but they do have clobetasol, and if you prescribe that, it's the equivalent." So the way pharmacies interact with general practices and how helpful they can be enormous, because otherwise I'm one person that could be sending them 10 prescriptions. "No, we don't have it. No, we don't have it," like a parrot. And the others are actually quite helpful. So I think that's good. I think that I've seen some really good services being provided, and I know you mentioned it in the report, the 24-hour blood pressure services. And I've had pharmacies begging me to send them work because they're not getting enough work sent through to them in a uniform way. And that's where the two services, being independent services, challenge each other. So I think it's a really positive thing. I think it's still in its infancy, and I think that the challenges out there through other areas, such as the internet pharmacy and the lack of an estate to provide it, are probably looming large on the horizon. But I think we're all enthusiastic to get that holy grail of a service throughout pharmacy. Thank you.
Thank you, Dr. I don't know if there's a question there or whether you want to. It was a good summing up. But I will say, add something to what you said about the interaction between pharmacists and GPs. Because now our local pharmacy, if there's a problem with a prescription, there's always complaining that his GP says he can't ring him up, he has to send an email, which delays it by a couple of days, when sometimes he wants an instant reply. Like you said, if there's an alternative drug or something like that to use, can he use it? So I think there is a bit of a breakdown there. I think relationships between GPs and pharmacists just need to improve a bit for this to work properly.
So two comments or answers, I guess, and thank you for all of the comments you made to this point, which has been really helpful and useful to us. The first is around relationships. I think, Councillor Doddy, you described a couple of different experiences you've had where communication works well and where it works less well. I think that's the importance of the programme of work we've got with general practice and community pharmacy about how we continue to improve that. The pharmacy who perhaps didn't send you the alternatives, I'm sure that wasn't intentional. It'll have just been not thinking through how we work together. I think we've come a long way in the last year and a half. We won't touch every pharmacist in the community yet. There's still a bit of work to do on that, but we are seeing that generally improve and want to continue to see it improve. And I think your example about how that's communicated, how that's resolved with good relationships, we can see that working really well in some areas, and other areas where we need to be more supportive, and that is our clear plan. The second sort of around was around the non-NHS prescribing sort of the clinical oversight, clinical governance, and it's an area where all of the medical directors of ICBs across the country are coming together to think through, along with NHS England, about how we might better support that. Some of that, I think, will be less of an issue when the NICE guidance allows NHS prescribing of some of the conditions that you can only get privately. So there'll be a commissioned route into that where the wraparound services are available. However, for some people, some of these services will remain private and outside the control and direct influence of the ICB, but still of interest, obviously, to us and wider colleagues. So understanding how we can improve safety, governance and information sharing in that field is an area of active dialogue and discussion with the national team around how we can make that better, but recognise it's still probably got a little way to go to get it where we'd like it to be.
Chair, just elucidation on the premises and estates to which pharmacies are currently expected to provide comparable service to sometimes acutely ill people. It just doesn't match up to what you would expect in a GP or an NHS surgery. It simply doesn't exist. And yet at the same time we continue with the illusion that it's a comparable service when it simply isn't.
Thank you for that. I don't think there are any more. Oh, do you want to come back to that? Sorry, Caroline.
Completely agree. I think the premises developments within community pharmacy have happened gradually over years. Before there wasn't a requirement for community pharmacy to have a consultation room, then nationally we told them you now need to design a consultation room in the premises and we're not going to support you, you're going to have to do it. Henceforth why you will see some of our pharmacies have been very creative with the premise they have. A bit of a challenge back. I don't think it's a comparable service. I think it's a different service. You can't compare general practices and the services they provide to community pharmacy. I think we have more to do as a health service to support community pharmacy provision. That is a challenge. It's even a challenge supporting general practice with premises developments at the time. So I think it is an area we, as an ICB and as a country and NHS England, do need to look at. I think they do their best. I think when we do have issues, we raise it to them and we discuss and look at what practical solutions, because they are struck by the same issues as we all do when we're trying to move premises development, premises, change of use of premises. So I think that is a fair challenge to us, and actually to how to look at how we do it. With regard to the workforce, with you're asking pharmacies to do two roles with checking prescriptions as well as providing clinical services, you're right. There is a piece of work being looked at by the department to actually change the regulations of community pharmacy. So currently within the community, if you're operating a community pharmacy, you are not allowed to open your doors until your registered pharmacist is on the premises. Okay, that isn't the case with general practice. You can open your doors with your receptionist while your GPs and nurses all arrive. But within the community pharmacy regulations, you're not allowed to do that. So what that means is that if we have a community pharmacy that's in their little consultation room doing blood pressure checks, COVID vaccinations, flu vaccinations, pharmacy first, contraception, they are waiting to check medicines. What the department is looking at is changing the regulations to allow that to be dispensed and checked by an advanced dispense checking technician. And having a look at how you do that remote monitoring, because that will truly revolutionise how community pharmacy pivots. But that is something that is being looked at the department with the National Pharmacy Associations, because it has a significant impact both on pharmacy training, pharmacy regulation and the provision of clinical services. So it is a really appropriate challenge and something hopefully we will see more coming out of the department.
Just like to add about sort of the workforce in community pharmacy, because that's changing as well in the same way that we've seen that with GP practices. So we've got our pharmacists, but we also now have technicians who are registered professionals, and some of the laws there are changing as well. So the regulations changed this year for them to be able to use patient group directives. Now, they can't take over pharmacy first just yet, which we've mentioned on patient group directives, because the training hasn't been put in place. But that is the direction of travel. So those regulations are changing, and the people that we're seeing working community pharmacy are wider to take in account of those skills. Our technicians, for example, can do the hypertensive service now already. So this skill mix is changing, but it is a process. You know, so in some places you will just have one pharmacist, when other places they may have two pharmacists, or they've got technicians, or they've got the accredited checking technicians, allowing them to do more. And we are also seeing IT changes. Some of the patient medication record systems are actually getting quite innovative as to being able to do some of the checks and identify which ones are high risk, which ones the pharmacist needs to see. So there's a lot of development in this area, but it's definitely, you know, it's an area in development.
What are patient group directives?
So patient group directives are a way of giving a prescription-only medicine, but without being a prescriber. So a patient group directive will state exactly who can and who cannot. So, for example, in Pharmacy First, we've got the urinary tract infection for women aged 16 to 64. So the patient group directive will state the ages. So actually, they can't go outside it. But they'll also state things like their health, whether their kidney function's all right, and various other clinical parameters. So it's a very strict set of protocols that say who is suitable and who is not.
Thank you for that. I don't think there are any further questions. No. I'd like to thank Alex, Dave, Caroline, Rebecca for coming along for this presentation this morning. It's as you've been said, it's in its infancy in early days, but I think there's a partnership building there between GPs and pharmacists, which would, I think, Dr. would admit, help the workload of GPs in the future. But it's just getting that relationship to gel, and I think in the partnership and the communication between the two groups there, I think there's a financial implication that probably for pharmacists as well, there represents what the work they're doing, which probably needs to be looking at as well. Again, our pharmacists, if they're dispensing and prescribing, they obviously need more staff there to do that, to help do it all. So again, there's a financial issue there. But I mean, hopefully, probably in its early days, if we probably come back in sort of 6 months or a year's time, probably just to update us on how this is actually working. It sounds to me like it's a good workload, and it will help and relieve the pressure of the GPs in the long term. But I think there's a way to go yet to build that partnership up.
Some of the outcomes from the independent prescriber pathway programme and the Pharmacy First, I think a year would be a good time to understand how they're playing out and where we are against that sort of pivot point in terms of change in service. So I think a year, 6 months, I don't think a lot of that information would be available at that point.
Thank you very much.
Just to reiterate as well the importance of really listening to what patients are saying and having a mechanism in place that's going to support gathering that feedback. Healthwatch can do everything that we can, but there's more that is possible really to ensure that in that year's time when we come back, you've actually understood the impact on patients, especially those that are vulnerable.
Thank you. Right, we move on now to the recommendations, and there are that's feedback of members on the changes to community pharmacy commissioning and potential impact of patient experience be noted, that the outcome of the quality impact assessment regarding the impact of changes to pharmacy commissioning be included in the next update on the ICB financial sustainability measures, and also going on Paul's comments later, that the pharmaceutical need assessment be considered for possible inclusion into our work programme going forward. Is that be noted, members? It's all noted. Thank you very much indeed. Thank you. Would you like to do a quick short break whilst we change to the next item? Okay.
Thank you.
Thank you, members. Right, the next item for consideration is an update on the implementations of the extended operating hours at the Newark Hospital Urgent Treatment Centre on a permanent basis. This update was requested at the April meeting. I would like to welcome back Alex and Dave, and also Steve Jenkins, who are going to present on this item. So we would like to start.
So it's me. Thank you for inviting us back today. Remember, we came a couple of times last year to talk through the urgent treatment centre at Newark, an area that's obviously very important to us. If you remember, the urgent treatment centre at Newark did have an issue about having to have numerous temporary closures due to staffing, and also the opening hours differed quite differently from some of the other urgent treatment centres in the area, and we wanted to create a situation where the future opening of hours for Newark was absolutely clear, consistently and ongoing open, so we could provide good information to our public about how it's open, how to access it, and what services they take. To remind you that Newark Urgent Treatment Centre does offer a wider range of services to people of Newark than a more standard urgent treatment centre, has more medical cover, and also offers a slightly wider range of services. So we went through a process which we described at length, where we were listening to our population about what was important to them, what services they wanted. There was then a piece of work with our local the East Midlands Clinical Senate, where they looked at the model of care, thought about what could be delivered, and how we should, how that compared to other urgent treatment centres. There was then an independent options appraisal, an IC board decision, and then implementation of the process. And what we're here to do today is describe how, from our perspective, that's going, from what we're hearing, how that is being embedded. The key thing for me is reminding ourselves that this is an urgent treatment centre. It's about urgent care, not emergency care. There's obviously some impact on emergency care, because some people use emergency care as an alternative to urgent care, and how that is working and how people are using the service. And we've got some information. And one of the key feedbacks from all of this was the fact that people were going early in the morning to avoid a morning rush, and the predominant demand was a morning demand rather than an evening stroke overnight demand. And that, in our view, is something that we need to resolve as part of this process. So I think I'm handing over to you, Alex, now about what's actually happened, and obviously we'll be delighted to take any questions.
Thank you, Dave. So I'm just going to talk a little bit, just move on to the next slide, around our communications with local residents about the new permanent opening hours. So we made sure that was quite a comprehensive piece of work that picked up both the new opening hours, but also really kind of shared the whole range of urgent and emergency care services which are available. That was one of the key kind of messages from the listening exercise, and also a recommendation from this committee that we set the urgent treatment centre hours in that wider context of all of the services that are available to Newark residents. We did that through a mix of both online and offline methods, again, based on a recommendation from this committee. Whilst many of us are online a lot, many people aren't, and so we made sure we had a real mix of, paper and outdoor posters and so on, as well as online digital routes. So in the paper under section 4, you can see how we did that. So I'll just run through a little bit of that. So jointly between the ICB and Sherwood Forest Hospitals, we issued a press release, which was picked up in the Newark Advertiser, East Midlands Today, BBC Radio Nottingham, and West Bridgford Wire. We specifically placed a column in the Newark Advertiser setting out all the alternative services alongside the UTC hours. We paid for 2 half-page adverts in the Advertiser, as well as a digital advert online, and that was seen 40,000 times across the period. We ran a digital billboard poster outside the Asda in Newark, We distributed an A5 double-sided leaflet to 44,000 addresses across Newark and the surrounding area, with, again, both those new opening hours and a description of the range of services that were available. We posted a considerable number of times across social media. We paid for advertising on Facebook, and 4,000 people we know saw that. We made sure our websites across both the ICB and Sherwood Forest hospitals were up to date, and also that what's known as the directory of service was up to date, so that other parties within the NHS are able to refer into the service accurately. That came alongside, given the time of year, kind of October into November, a wider communications and advertising campaign that we run most winters to really promote the availability of NHS services over that busy winter period. So we made sure that we had reference to people looking after themselves and avoiding flu, the opening hours for pharmacy that we've just been talking about over bank holiday periods, making sure that people were hearing about NHS 111, but also access to mental health services. As part of that, we were also promoting Pharmacy First, which again we've just talked about, helping people understand how they can look after the health of their children over the busy winter period. We recorded a number of videos with GPs to outline the range of services that were available. And we've also recently launched a WhatsApp channel specifically to promote what services are available, the opening hours of pharmacies, how to protect yourself from flu and COVID, and how best to get a GP appointment. So you can see we're doing quite a lot. We really want to promote the service. We really want it to be well used. We really want to create trust amongst the population that urgent care services are there for them. You can see some of the visuals of some of that up on the screen there. So next slide. I think Steve can talk more about this, and I'm sure there'll be questions, but the new opening hours have been implemented, and I think implemented really smoothly, and we should put on record our thanks and the thanks of the Trust to the really positive and mature way that colleagues who work in the UTC have really embraced the decision and kind of worked with Trust leaders to find the right way to implement that. One of the ambitions and one of the real kind of bits of feedback, as Dr. Briggs has touched on, is that there was quite often a queue outside of the centre before it opened first thing in the morning. And you can see quite neatly on this slide, on the left-hand side, there was that real spike at kind of 9 o'clock. And on the second chart, you can see how those first two bars add up to about the same volume of people, but we've managed to spread it slightly earlier in the day. So there's less of a rush, there's less queuing, there's less kind of sudden surge of demand for the colleagues working in that service as well. So whilst it's early days, that does feel like a kind of early sign of a positive place for us to be. Overall, the attendance is about the same with those kind of increased hours. We're seeing about 100 patients a day if you look across October, November and December, so both pre-new opening hours and post. But yeah, we've been able to kind of smooth it out across that kind of longer period of hours. And credit again to the staff that work in this service. The friends and family test, which is one of the ways we really kind of check how are we doing, how's this feeling, what's the experience been like. Incredibly high scores maintained for this service as we move forward, even across winter. So again, we should say thanks and well done to those colleagues. So that's probably it in terms of kind of presentation, but happy, Chair, to take questions.
Yes, thank you. I mean, you probably know there's a people in the Newark area are still trying to get the 24 hours, still for the 24 hours opening. And I actually think we need to get this message across of what you're actually doing at the moment. The urgent treatment centre is working. I think a little bit of the problem is people use it as a GP service because they can't get into the GP, so they go to the urgent treatment centre instead, which is a little bit of an issue. And I think about advertising, I mean, if you Googled Newark Hospital up to about a couple of weeks ago, we still say got a 24-hour service open. So I think that was a little bit of communication that went wrong there. And unfortunately, the Newark advertising circulation isn't great either. But I know you do your best to get the message out there. And I think the message is out there. Good things are happening in Newark, and I know I hear myself that it is working very well. It's doing a lot of daytime operations and clinical things, which is helping take pressure, I'm presumably, off our other hospitals as well. So I think it is doing a good service. Councillor Martin.
Yes, Chair. Well, where do we start? At the beginning, I think. After talking to Councillor Darby about this issue, who is the ward member for Bridge Ward at Newark, and myself having experienced the villages of Newark, I don't know if you've ever walked around Coddington or Collingham village, but I've never seen so many spinsters and elderly ladies living on their own in a village in my entire life. And the crux of the matter is that in 2010, the NHS managers decided to get rid of the A&E at Newark and replace it with an urgent treatment care centre, therefore forcing people and EMAS to transport people nearly 45 minutes away to Kings Mill, which I must say they do very well at, and they've got an excellent record of dealing with A&E, and that's not the issue. The issue is that the NHS changed what they promised. So at the time when they shut the A&E in 2010, they promised to keep 24-hour services open at Newark. And of course, those people in Coddington and Collingham don't forget, and some of them are still there, because it was only 15 years ago. I know most of them are probably 85 now, but they don't forget. So what I'd like to ask Alex, while he's here in the room, because we've been over this argument and we all understand that an A&E has to have a full and wide comprehensive range of services in order to be an effective A&E. That's not the argument. And the other side to the problem is that all of these statistics on here are great, but they are in relation to an urgent treatment care centre. They aren't in relation to A&E, which is what was there before. So these statistics here show when the A&E is being used, and of course that adds validity to the way that it should be open longer, and Newark have responded to that and done that, and that's great. But rolling forward, let's look at all of the district councils, which were, well, I'm not talking about government reorganisation, I'm talking about local plans. So Newark is set to have 25,000 new homes built around it. Ashfield's set to have nearly 10,000 built around it. I dare say Gedling and Newark and I dare say other boroughs are the same. So my question to Alex would be, going forward, because the residents of Coddington and Collingham and the outlying villages of Newark feel like they've got a two-tier health system because they have to be transported by EMAS or relatives over. It's a 2-hour trip, easy, and that's without stopping at A&E. What would we be doing going forward to improve the situation at Newark Hospital over the next 10, 15 years? Because they've lost that service, and I'll tell you the way to the argument. Opposition to the plans included a 5,000 name petition and a human chain around the hospital. And I'll take you back to when they wanted to take some oak trees out at the county building. You'll know how aggressive people in Newark can be. And let's not forget that's where King Charles was captured. So what are we going to do going forward? That's the question, because we know we're not going to get A&E back at Newark, and we know now we've got the urgent treatment care centre open as much as it's going to be possibly open within the parameters set for an urgent treatment care centre. The statistics prove that, Alex, and they're great, but they are about an urgent treatment centre, not about A&E. So going forward with the planned expansions of building, what are we going to do?
Thank you, Councillor Martin. I know you appear to have threatened me with regicide there, so I look forward to being captured by your parliamentary forces at some point. So look, what we're here today is to talk about how we've implemented the decision that we've been made. You've taken us back in time quite a bit. I'm keen that we look forward, so that's a helpful framing. I think there's probably two things I'd say. One is there is a 24-hour service available to residents of Newark and the surrounding area. It might not be through the urgent treatment centre, but if you need care overnight, including if you need a GP appointment overnight, you can access that. That's the universal service which is commissioned for those residents, and you access that through NHS 111. So I don't want anyone to go away from this, or the people of Coddington and Collingham who might be watching on the live stream, to think there is no care available for them overnight, because that would send the wrong message and would, I think, alarm people. We need to be clear. If it's clinically appropriate for you to receive care overnight, you can access that. So, and second point is, we recognise that there is growth in the population of the Newark and surrounding area. There seems to be some ambiguity, shall we say, about the exact scale of that, and I hear a wide variety of figures quoted about how many houses are being built and how much the population is growing. We should be clear, though, that over the previous 10 years, the population of Newark has grown by about 6 or 7%, and that's about the same growth that the whole of England has seen. So there isn't a disproportionate level of growth historically in the Newark area. There may be going forward, and we're working closely with the planning authority at the district council to really understand that. And we will monitor that. We will monitor that through the joint strategic needs assessment in partnership with the council. We'll monitor that through working with the district council. And if we see a level of population growth that means we will need to update the services available, we'll do that. But I don't think you're asking, but for avoidance of doubt, that would be, I think, extremely unlikely, Dr. Briggs, to include an A&E. And at the moment, based on the demand that we've historically seen for a 24-hour service, it doesn't feel like there is demand there in the future for us to move to that. But we're not saying never. As the circumstances change and as we see more kind of concrete change in that population and the size of that population, we will make sure services respond to that.
Thank you for that. Again, it's the numbers, isn't it? And the lead. Yeah. Councillor Wilmot.
Thank you very much, and thank you all of you for the extremely important briefing that you've just acknowledged. But you do say that after consideration with elected members and groups and so forth, that you've actually increased the service in the opening hours of the centre. But people have been screaming at me saying that isn't actually true, because it's not an increase in the service. It's just an extra half hour to see the people that you're already just come in for 9:30. You're not increasing the opening hours of the centre. It's just an extra half hour you're putting on so that the patients that have come in at 9:30 will be seen and won't have to be paid overtime. That's what people are screaming at me. Actually, they're saying that no extra patients will be seen because the patients that are already in the centre by 9:30 will just service just becoming extra half hour to be able to see them and sort their problems out. I just wondered what the answer to that one is.
The answer is, previously the centre was open from 9 a.m. to 10 a.m. You don't need your big calculator to work out that's 13 hours. It is now open from 8 a.m. to 10:30, which is 14 and a half hours. So that's a simple statement of fact. I don't know, Steve, if you want to talk about what that's like in the service.
Yes, morning everyone. I'm Steve Jenks. I'm Divisional General Manager for Urgent Emergency Care at Sherwood Forest. Thank you for having us this morning. So yeah, we are open slightly longer. So we open at 8 o'clock and close at 10:30. And yeah, the unit will remain open for patients and accept patients between those hours. I think just picking up on, you mentioned something about overtime.
It would have been overtime before, but now you're putting an extra half hour into the situation just to see the patients that are already in there by 9:30.
Yeah, so I think the 30 minutes that you're possibly talking about, Councillor, is the like close down time, if you like. So what we used to have previously was like a 30-minute time at the end of the day where it might be close to accepting new patients to be able to deal with the patients that are already in the unit. Following the clinical Senate review, the recommendation to increase that, and as part of the extension of the opening hours, we also extended that. But we also opened, as we said, an hour earlier following that consultation. as you know, the public had said that they wanted to get in a little bit earlier. They'd wanted it open slightly earlier. So yeah, as part of that review, we're now open at 8 o'clock, and yeah, the slide shows that it's enabled that smoothing out, that big queue in the morning, smoothing out of that presentations, which also supports not just the patients but the staff, and to get patients treated, seen as timely as possible. Does that answer your question, Councillor? Sorry.
No, not really, because all I'm saying is you're saying that there are extra services, extra time for service. That extra time is not for services. It's just to treat the people that are already in at 9:30, and so that stays the same.
I'm not quite sure where you're coming from, Councillor Wilmot, because they've extended the hours to an hour and a half extra, which allows more people to have access, especially early in the morning. You know, if people want to go there. So,
Chair, point of clarification: can we say that if the service was open to 9:30 for the last person to come in, and it was closing at 10 and it now closes at 10:30, the same number of people will be there at 9:30 as was previously? And Councillor Wilmot's point is that the extra half hour doesn't cater for new patients at that time of the day. I'm not saying it doesn't cater for it in the morning. The point of clarification is simply that the extra half hour at the end of the day is an administrative half hour, which is the point Councillor Wilmot is making, and it seems a perfectly clear, simple point. I don't see any ambiguity about it at all. It's a very valid point. Thank you.
Councillor Henshaw.
I'll keep my comments to the report and not to the First English Civil War. And I suppose as an ardent parliamentarian, I would have been on the outside of Newark looking in, and we'll see how that. Well, we all know how that worked out. In relation to the report, I think the people. I go to Newark quite often. I think the people of Newark could accept the service that's provided by the unit. I think the unit is becoming more valued, and the service that they provide is being more accepted. There may be a point that Councillor Martin made in relation to future developments, but as quite rightly been said, those future developments will be looked into in the future. But the extended opening hours were originally intended to go start in the summer, and it was delayed for a period of time because you're saying you wanted to consult with the workforce. Now, presumably, the outcome of those consultations with the workforce were favourable because it's the recommendation now are being implemented. I just wondered what really came out of the consultations with the workforce. Did you learn anything by consulting with the workforce? And presumably the actions that were subsequently taken were mutually agreeable, so that the service could be provided in a new way. Thanks, Chair.
Yeah, thank you, Councillor Henshaw. So, yeah, it's a statutory duty for the organisation to consult with staff on any significant changes to working patterns, for example, which this extended opening hours did result in. So our consultation was, how we ran it is, we run group consultations with staff with the proposed opening hours. We put forward a proposed staffing model for those new opening hours, which would have, our initial proposal resulted in staff that typically work a long day, for example, 13 hours, and that would be split into two due to working time directives, etc. So as part of that group consultation, the staff were really engaged with, we ensure that we engage with every member of staff within that department and surrounding services. And following that group consultation, staff put forward a counter proposal, which then just extended and slightly delayed that kind of legal requirement of consultation. We obviously, as an organisation and a system, listen to that counter proposal. They work the shifts, they are on the shop floor. and we subsequently supported that slight change in service delivery because they felt and we agreed that to deliver a better service to the population. And then following those group consultations, we had to conduct one-to-ones with each of the staff members around some of the changes to opening hours and working patterns. So that did cause quite a slight delay in his opening, but we felt it was a worthwhile exercise to listen to our staff, and not only our staff, a lot of the staff are residents of Newark. So it was really valuable consultation period, and we apologise if it did result in a slight delay, but I feel that we went through a quite robust process that the staff are engaged with, believed in and supported, and that's enabled us to smoothly implement in time for winter, which was that was the kind of most pressured time of the year. So I hope that answers your question, Councillor. Thank you.
Thank you. Councillor Bailey.
Thank you very much, Chairman. As you'll be aware, it's quite a controversial. It was originally quite a controversial decision. I know lots of Newark representatives have been critical of healthcare service in Newark. In particular, my colleague, Councillor John O'Leigh, who unfortunately can't be here today. I suppose my question then is, as there's concern about any downgrading in service in Newark, with the statistics you've acquired, does that indicate that there'll be no need for any reductions of services in terms of hours? Are you quite happy with the hours you're offering, and do you see there being need to increase those hours? In addition, what investments are going to be happening in Newark in terms of so people in Newark can see that actually they're not being forgotten? They will be seeing some increases in the healthcare offer aside from the urgent treatment centre. Thank you very much.
So I'm happy to kick off, and Steve might want to talk more broadly. We can never make commitments about the future, perhaps to the level of certainty that you might want. But what I can say, and I think what we've said frequently, and I hope loudly at this committee and elsewhere, is that there is no question over Newark Hospital. Newark Hospital is a highly valued asset for its population. It's a highly valued part of our health and care landscape, and we want that to continue well into the future. So that's the kind of starting point that we're on. We need to make sure we're making maximum use of all of our health and care assets to get the very best value for our budget. And that will probably mean changes. It will mean more services happening in some areas. It might mean fewer services happening in other areas. So we can never really be, I think, certain, nor we would want to be fixed about this will always happen here. But our commitment as an integrated care board and as a trust, to talk on their behalf, to Newark Hospital is not in doubt. And we will want to grow, I think, the services which are delivered in Newark Hospital. You've seen previously quite considerable kind of lists of further investments into the hospital. That includes the breast clinic and hearing services and new modular operating theatres. There's a whole long list that I now can't recall, but we've definitely brought it to this committee before. But Steve, you're again closest to the leadership.
A little bit closer. You don't want to hear about my career today, but previously to this role, I was the general manager of surgery and critical care at Sherwood Forest, and yet, as Alex rightly pointed out, said, it's a valuable asset, Newark Hospital, and it's ideally suited to grow a lot of services. And over the years, if I think back to when I was the general manager of surgery, for example, restarting elective orthopaedic inpatient operating, such as hip and knee replacements, that had been missing from Newark for a very long time. So as an organisation and as a system, we're committed to growing appropriate services at Newark Hospital, and we'll continue to work together to do that for the benefit of the Newark residents and local population. I think from an urgent treatment centre perspective, yeah, if you look at that profiler attendances and the kind of case mix of patients that do attend, I think the open hours are more than appropriate. Yeah, should we see that increase in population and increase in demand, that's for us as an organisation and system to work together on how we ensure patients still receive timely and appropriate care, and that might mean we have to put another doctor on, for example, and another nurse in peak presentation times to ensure that they continue to get timely and appropriate care.
Thank you. I don't think there are any. Oh, sorry, Councillor Eddie.
Sorry. Just to say thank you so much, because I know this. I feel like last year we spoke about Newark Hospital near enough every single meeting. It seemed at one point we seemed to be talking about it a lot. And thank you for bringing it back and explaining to us what you've done and how it's working. I suppose my only question is, I know with staffing that was one of the major issues when we talked about it before, because it was going from one shift, so I'm glad that that's been sorted. And then the other question I've got really is, with the attendance at the moment, so in December it was about 300 up from last year. If it continues to grow like that, is it sustainable with the staffing and the levels it's covered at the moment?
Thank you, Councillor Eddie. So if there continues to be kind of that large growth, then we need to look at our response. So yeah, we do on a frequent basis look at what's happening with demand, the types of presentation, so whether it's primary care or whether it's minors presentations, injuries, and how they profile attend through the day. So like in the chart, so we review that on kind of a monthly basis, and we would respond to the need of them presentations. So yeah, if it continued to grow and people were turning up at 8 o'clock in the morning, we start to see that spike, yeah, then we would certainly respond to that. And as I said, put the staffing in. We're quite lucky, I think, from a UTC perspective. We've got a good amount of space. So yeah, there's rooms that we could put additional staff in and be able to manage some of that demand. So yeah, I'm confident that the kind of waiting here, we wouldn't need any large infrastructure changes to enable us to accommodate that demand. It'd be more around having the appropriate clinical staff to deal with that additional demand. Thank you.
Thank you, members. Any other questions? No, I'd like to thank Alex, Dave and Steve for coming along and giving the presentation and answering questions. I think the argument for a 24-hour hospital will be going on for some time, but I think it's really down to the needs and resources there. You know, if the growth of population demands it, I think it's there, because I think before, when it was a 24-hour, the actual numbers of usage were very, very low. So there wasn't really a business case for it today. You know, the cost per patient was very, very high. And also, EMAS do provide a really good service. They can stabilise patients in their ambulances very well to get them to mainline hospitals. And Lincoln's not very far away from Coddington or Collingham. You know, it's less than 20 minutes, half an hour with a blue flashing light. So I think, you know, the ability to get patients to an emergency hospital is there. Not necessarily have to be in Newark, but I'm sure Newark will always be reviewed going forward to see whether it needs to be upgraded with the demand of the area. So the recommendations we have is that the feedback from members and on the implications and communication of the open hours be noted, and that further update considered for possible inclusion in the work programme 25-26 as appropriate. Okay, so okay. That meet with members for noting. Thank you very much. And again, thank you, Alex, Dave, and Steve, for coming along this morning. And that's right. Thank you. Thank you very much. Were you around Hero Cavalier? That's what I don't know. Thank you, members. We now move on to the work programme. And I'd just like to highlight a few items in respect to the work programme. Members will be aware that the next meeting is on the 18th of March due to pre-election period, and then there won't be another meeting, and then probably till June after the election. So there is quite a gap until we meet. And further to the priorities already on our work programme for the March meeting, we are aware of the headlines that are deeply concerning and have requested that updates regarding pathways development for the crisis and community mental health and additional information that was requested regarding Rampton Hospital and the Caldane incidents now, which is going on, although it's a bit of a police matter. But I think it's only right that we as a committee do get updates on that because it's something happening in this county. And we have also requested an update regarding maternity services, which has had outcomes from the CQC delayed and Don Oxford's investigation extended. Again, there's more information coming out with missing papers and missed things. And again, I think because there's something happening in our county, we need to have updates on this. Two very important national incidents, really. More patients. Yeah, they have. Yes, so we missed. Yeah. So, and also we are going to request feedback on the ICB's engagement regarding the fertility policy programme review. They did promise to come back in March. They're saying they won't have enough information, but I think they need to come back because we haven't got another meeting until June. There's a big period then when they were supposed to be releasing their results of the consultation and everything. They could get missed by this committee. So I think we do need a little bit of an update at the March meeting. And also to remind members, we've organised a site visit to the National Rehabilitation Centre at Stamford Hall, and this is on Wednesday the 19th of March, 2 till 4. Are we having the bus or are we going our own transport or?
We are on our own.
On our own.
Car sharing.
So we can car share, meet here, so say 1 o'clock for those members who wish to go. Yes, it has been put in our drives for February.
It should say February. Shall we move to March? Well, I'll take care of it.
Actually, it was in the drives for February. You're right, actually. Yeah, definitely. Yeah, okay. So we'll make it 19th. Well, yes, it will be the same day, 19th of March. Yeah, give a bit more thing. Okay.
Can I just clarify 2 other issues, Chair? May I? So just to say, our next meeting after March is on the 1st of July, because the lead time in order to get all of the papers and all of the members and all of the responsibilities allocated after the election will take us until that date. So that's the earliest date that we can have that meeting. So just to let members know that it will be very early in July, but it is the 1st. And then as far as the missing papers that has been discussed in the press with NUH, that is a police matter, and it's not something that we would be able to scrutinize or discuss in this committee in March. However, once that is resolved, then we would be able to scrutinize the findings or any outcomes that are from that investigation. So that's just something to clarify, Chair.
Sabrina?
Yeah, just a quick question, because the other thing that was in the press was about families being mistold about being termination of their pregnancies. Is that police matter as well, or is that something that can come to this?
It's all part of the same issue, isn't it? Really, yes, yeah. Which I think we will look into that and get some updates for the meeting. I think it's important that we do get updates because we've got a 3-month gap before we then have our next meeting. So there'll be a lot of information that could get lost within that period. And as always, if members have got any other issues they want to bring forward, Councillor Bailey.
Thank you very much, Chair. As some will be aware, the Nottingham Post released an article yesterday raising concerns about strike action in Bassetlaw. This is due to a dispute between staff and the Trust regarding the rotations from Doncaster, Royal Infirmary and Bassetlaw Hospital. Now this has caused significant concern locally, particularly concerns that staff may have to travel over an hour. So I suppose my request is, as you mentioned, dates are quite tight in terms of when would be even be able to discuss this item. So would it be possible for the Health Scrutiny Committee to have a meeting with the Trust to highlight any concerns that we have about this?
No, thank you, Councillor Bailey. We will try and get an update if we possibly can for the March meeting. March meeting might be a longer meeting than normal, but because getting all the information out because the things are occurring, and that's an important one. Again, we just could do with an update. Councillor Martin.
Yes, Chair. I'm not going to go over old ground. Well, I am actually. Back in 2019, when the Conservative government was elected, they promised to build 40 hospitals across the country. And of course, Queen's Medical and the city were part of that programme. And that programme got delayed because of the crumbly concrete programme and whatever. And since Labour were elected, we now find that the rebuilding of the new QMC is going back to be beyond 2030. And I think it's about time. I propose that we actually write to or invite Wes Streeting to this committee to answer the question as to when we're actually going to get this built, because these things take a long time. And I'm saying this because, you know, some of us in the room may not be here after the election, and I think it's important that we put that in place before the election, because it takes a very long time on the rebuild programme, and I don't think we've had a proper answer from this government. So I think we need to demand an answer or an update for the March committee meeting as to when that new rebuild scheme is going to actually take place.
Yeah, I think Catherine's going to answer. I have actually written to Wes Streeting from the Health Committee about this, and it's basically this government prioritising where it spends its money. You know, obviously the NHS is not its important thing because the QEMC was fairly advanced. It has a team in place actually doing the work to what was needed, but unfortunately. I think Alice would tell you they wish they could find some rack concrete because those hospitals with rack concrete have been prioritised now as those without it. But I think Catherine wants to say a bit more.
So, just to let members know that the update that will be brought by NUH regarding the maternity services will also talk about the tomorrow's NUH program and how these decisions about the new hospitals program will be affecting how that unfolds. So we don't have answers today, but we will hopefully have a good discussion about it in March.
John.
Thank you very much, Chair. Oops. Thank you very much, Chair. Members will not be surprised to hear me to ask this because of the forthcoming election and to make sure that it does get looked into. But with the delays in the rebuilds, of course, in the city and QMC, it's become a more critical situation. I've asked for this on multiple occasions, but it seems very few people are listening. Could the Health Scrutiny Committee of Nottinghamshire County Council urgently use its influence to investigate the situation regarding the pausing of the Cavill Centre in Hucknall? This has been on the work programme now for well over a year, and if we are able to secure the visit of Wes Streeting MP, can we ensure we ask him about the urgent healthcare questions facing residents in Hucknall and across Nottinghamshire? Absolutely essential that because of the upcoming elections, nobody knows whether they'll be here to represent their people after the elections. It's absolutely essential that I get something done before that time comes. Thank you.
Yeah, okay. We will check with any new information on that going forward. We're always on the work programme. I'm sure Council you will always raise that. Yeah. And going back to David's point about NHS, well, the money is there, it's prioritising whether it's more important to give railway workers a big pay rise or put money in NHS. You know, there we go. Anyway, the recommendations are that the work programme and scrutiny criteria be noted, That authority be delegated to the Health Scrutiny Lead to update the work programme as appropriate in consultation with the Chair and Vice Chair and representatives of the relevant partner organisations, with any change reported to the next meeting. All remains to say, members, is thank you for here today. It's been a very good meeting. And the next meeting, I think, will be a long one, but I think there'll be quite a few important things to discuss, highlighted, which are happening in Nottingham with the health issues at the moment. So thank you very much, and we'll close the meeting. Thank you.